The following activity is brought to you by the American Urological Association.
Good afternoon. My name is Jay Raman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series with this specific episode titled Modernizing Urology Care, the Current and Future State of Virtual Care in the United States. My guest today is Dr. Chad Ellimoottil. Dr. Ellimoottil is the medical director of virtual care for the University of Michigan Medical Group, the principal investigator of the Telehealth Research Incubator Lab, and an assistant professor of urology at the University of Michigan. He is a principal investigator, as I mentioned, of the Telehealth Research Incubator Lab. And at this level, they do have funding with an R01 grant mechanism from the AHRQ and the Michigan Health Endowment Fund. He's certainly spoken in a variety of different settings about virtual care in both the private and public venues. And it's really our pleasure to be able to host him and obviously get about 30 minutes of his time to talk about this important topic. So Chad, first of all, really good to see you. Appreciate you taking the time, and thanks so much for joining.
Yeah, of course. Thanks so much. It's always a pleasure to talk to you, Jay. And I'm excited to be here and talk about a topic that I'm obviously very, very passionate about.
That's great. So let's maybe just start off and maybe just give us a sense, even maybe before we get into telehealth, how does, it's always sort of, I don't want to say it's a path less traveled, but, obviously we all go through training and we learn all the clinical medicine and we, how to do this, how to do that, the biology of this disease. Maybe just give us a little bit of a sense of how did you sort of carve this niche for yourself? How did this become an area that you have focused on and obviously focused on so well? Just give us a little bit sense of yourself.
Yeah, sure. No problem at all. I would love to talk about that. I often actually get that question when people find out I'm a urologist and they're like, wait, you're a urologist and can you even do telehealth for urology? And actually that's where my story begins. I've always been interested in healthcare policy, and I knew that I was going to integrate healthcare policy with my practice and research, but I never really thought that it would be so focused on virtual care. And that interest started back in 2016 when I joined the faculty at University of Michigan. And we're seeing patients from all over the state. And perfect example where, I'm a general urologist here. And so very commonly we'll see patients that have kidney stones. And so I would, look at where these patients were coming from, and they're kind of coming from all over the state, traveling 2 hours for me to tell them that their stone looks stable. I'll see you back in 6 months. And so, as I was going through that practice, I realized that there had to be a better way. And University of Michigan at that time did not have a very sophisticated virtual care platform. And so I sort of cobbled together a system, and the payer in the state was starting to pay for visits from home. And, after I did a few of these visits, I said that this made a ton of sense, and I started to learn more about it. And then I realized, the only thing that was holding this back, this thing that made a lot of clinical sense, the only thing that was holding this back was healthcare policy. So what a perfect intersection where I could focus my career on how can we change healthcare policies so that we could, provide this type of care for patients. And it just took off from there.
That's great. That's great. It's really nice to hear. And having done so many of these episodes, one of the really neat things is seeing how different people have sort of carved areas of interest in different niche areas that, and I think most of us maybe, as you're going through training or even medical school, you don't even think that's going to end up being your focus. And lo and behold, it is. Exactly. So Chad, one of the things that I'd love to hear your thoughts on as our audience is, so we all know that, COVID-19 pandemic, early parts of 2020 going into the latter 2020, we saw that surge of use of telehealth, whether it's video or telephone. And, and obviously that was out of necessity. And now here we're several years later, we're more of a steady state, perhaps. Maybe the acute issues of a pandemic are really not in front of us. So where have we, give our listeners a sense of where have we settled out a little bit? What's the current state, maybe practice patterns, and what are the policies, both at a state level and maybe at a higher level?
Yeah, that's a great question. I think we have come a long way since the pandemic, and that was really the peak of using virtual care for the reasons you mentioned. It was out of necessity for social distancing, and It's kind of it's crazy to think when I look at the calendar that was about 3 years ago. And over the last 3 years, we've really seen, um, you know, I would say there's changes in the patterns of use of virtual care, but also a lot of stability. So when we initially during the early parts of the pandemic, about 50% of care, this is across all specialties, was virtual. Those were the first few months, but in July of 2020, people started to want to come back for care, and healthcare systems were safer, practices were safer, and so the demand for in-person care increased. And what we saw over the last couple years is that it's plateaued, and it depends on what payer you're looking at. I do a lot of research and analysis following trends in the Medicare population, and right now in the Medicare population, it's about 1 out of 10 outpatient healthcare encounters are through virtual care, and those numbers are a little bit higher in the commercial populations that we follow, where it's about 1 in 5, 1 in 6. So that's where we've sort of leveled off for a couple of years. And now that as we look forward, I think that people are pretty settled in their ways, but now I can see a lot of practices and health systems thinking more strategically about the use and making it available for patients, but then also thinking about how can they make their their practices more efficient, and where can virtual care be put in where they can actually see some productivity gains as opposed to just the necessity to do it.
Mm-hmm. Mm-hmm. And where are we at sort of like a higher level, like policy perspective with regards to telehealth and virtual care? Where are we from a government perspective on that?
That's a great question. And to be honest with you, over the last couple of years, there's just been so much uncertainty, and that's kind of kept a lot of practices from investing in virtual care, just because we didn't know if there was going to be reimbursement 60 days from now, a few months from now. Mm-hmm. And so, but that has actually become a little bit more certain. The biggest milestone since the big deregulation that occurred in March 2020 was the year-end spending bill that was signed at the end of December 2022. And this, you may have heard about it in the news. It was called the Omnibus Bill, which included a lot of different provisions for many things. But one thing that was solidified in that spending bill was coverage for virtual care for 2 more years. So for 2 more years, virtual care or telehealth visits will be covered by the Medicare program, and audio-only telehealth will be covered for the Medicare program as well, and that's to the end of 2024. So effectively till 2025, that coverage is there. So that brings a lot of stability for us to know, or for us to bank on that virtual care will be covered, especially since most commercial payers follow suit with Medicare, and Medicaid certainly is very pro virtual care too. So I think we're good from a payer standpoint. I mean, I think the bigger policy issues, which I'd love to get into with you, is that we're still uncertainty about the final shape and form of virtual care in 2025. There's a number of different issues out there that still need to be worked out. There's very strong bipartisan support, like overwhelming bipartisan support that telehealth is a good thing, but it becomes a little contentious when you get into the details of what should be covered and should it be covered at the same rate and so forth. So we'll still need to see some legislative action on some of those points. But I think in general, very optimistic that for the most part, the day-to-day practice of virtual care will be around for 2 years. And at that point, we're 4 to 5 years out, and you can't, it's already, cat's out of the bag at that point, and it's not going to get rolled back at that point.
So I think you alluded to this a little bit. So you've sort of brought us up to speed on where we are and over at least the next 2 years, due to the year-end spending bill, the ability to have telehealth coverage. So let me ask you a few sort of issue questions and your thoughts and how we're going to deal with this, or what's currently in practice. So what about interstate telehealth, and how does that work, and what are some of the barriers there? Talk to us about that a little bit.
Yeah, that's a really good question. It's actually one that comes up quite a bit in conversations. And so just for everyone's sake, a definition of interstate telehealth, another way of calling it is cross-state telehealth. So, if I'm a provider or healthcare provider that's licensed in the state of Michigan, technically I'm only supposed to practice medicine with patients that are physically located in the state of Michigan. So if that patient who lives in Michigan that I've had for many years takes a vacation in Florida, snowbirds in Florida, technically I'm not supposed to practice medicine with them unless I have a license in that state. So that issue of in that issue of interstate telehealth is important for those cases, but it's also important for more practical reasons too. So we're in Southeast Michigan, our university, and so we have a lot of patients that are right across the border in Ohio, 45 minutes away to the Ohio border. So technically, if they're at home, I shouldn't be performing telehealth with them because I'm not licensed in the state of Ohio. So a lot of practical implications. During the early part of the pandemic, all 50 states and DC relaxed these licensure regulations. And the licensure regulations are at the state level. It's not the federal government, it's the state government. And so they relaxed those licensure, basically gave waivers to perform cross-state telehealth. But then over the course of the last couple of years, those licensure waivers, which were often tied to emergency orders of the state, started to expire. And so at this point, I think there's about 9 states that have these licensure waivers still in place. But for the most part, we're kind of back to normal on not allowing cross-state telehealth. So that's going to be a big question that comes up. I mean, those couple examples I brought up are real examples, and you didn't really think about it when patients were traveling to you, but when you're quote unquote traveling to them through telehealth, it becomes a big deal. I'll tell you that I honestly am a little pessimistic about that we're going to get anywhere by 2025 on this issue. People are all over the fence on allowing cross-state telehealth, especially at the policy at the policy level. And so, and the fact that it's 50 states and 50 states can make their own decision, I think kind of herding all the states in one unanimous way is going to be very difficult. So, I don't know if, I doubt that in the context of this podcast, we can get into all the nuances, but it's not just about licensing. It has to do with malpractice, disciplinary action, insurance coverage. As part of the health system here, I have a lot of healthcare providers that are interested in it, and they have these cases that make so much sense, like a pediatric cardiologist who specializes in congenital heart disease, needs to see patients from many states in order to fill their clinics. And those patients are driving multiple states to get to them. So there's these cases that make a lot of sense, but unfortunately, there's still a lot of regulation tied around it that makes it very, very difficult.
Interesting. What about payment? Payment parity? Maybe talk a little bit about audio, maybe versus audio visual, and where does this all play out, and how are we going to sort of find a happy medium with those types of visits and in-person visits?
Yeah, that's another big contentious issue as well too. And so far, since the public health emergency rolled out, the Medicare program, and as far as I know, a lot of commercial payers have been paying at parity. And what that means is that if you see a patient in person and if you see them through a video visit, you're essentially getting paid, roughly about the same amount. Which has been a good thing. And that's been, and to me as a clinician, it makes a lot of clinical sense too. If I see a patient and I talk to them about kidney stone surgery, whether I do it in person or whether I do it through video, it's the same content. And I've always sort of felt that we should be paying for content, not necessarily exactly what goes on during that visit. And so and to that, if you extend that philosophy further, then audio only telehealth would, should be covered at the same level as well too. But that's my perspective on it, and of course I'm biased because I'm a clinician and so forth, and people view it otherwise. And it's hard to explain, the optics around paying the same amount for audio only telehealth or telephone calls is it looks bad. And so it's like people often will say, and patients will say, well, I just got a phone call. That can't cost as much as an in-person visit. And oftentimes the argument that I'll make is, well, there was a scheduler that scheduled that. There were some tests that were ordered that need to be followed up on. There was a nurse that is going to help with the, peri-clinic care. And there's still a brick and mortar clinic that needs to function, even though the visit was just done on the phone. So if you take all those costs into consideration, it is actually about the same amount as an in-person visit. So I think there's a lot of complexity to it. Unfortunately, the narrative to pay less for video and audio is really strong. So and the narrative against it is pretty complex. So hopefully, that message can get across with policymakers and so forth, and we can hopefully stay at parity. But I don't know where this issue is going to go in the future.
Sure. So what other, maybe just in the current state, what are some of the other policy challenges? We talked about cross-state health. We talked about the payment parity. What else do you think is important for our listeners to know about in our current state?
Yeah, so I think that those are probably the two biggest issues. The main thing really is whether or not, fundamentally the big question and what's driving all of these policy questions is really about what's the impact of virtual care on overall healthcare spending. So if there was no concern about that, we wouldn't be thinking about all these different issues. And so the other big policy issue I think that's important is whether or not there should be these clinical guardrails around who can get telehealth and who can't. And those guardrails, again, are the reason they would exist is because of the worry about excessive healthcare spending. So one good example would be for mental health. There's a proposal that has actually been held back with this, with some of the legislation, but it's a proposal for mental health providers that you can see them through virtual care, but at a certain amount of time, in 1 year, you need to see them in person. And that might not necessarily be built on some sort of clinical evidence that says that you're delivering better care if you see that person in person once a year. It's really built on the fact that policymakers, insurance companies don't want, they think it may be abusive if you're only seeing them through virtual. So in the future, if those types of clinical guardrails apply to urology, like you can see a person 2 or 3 times in a year virtually, but every year you have to see them in person. It creates all this complexity, and as a person that's trying as an administrator, it's kind of hard to, how do you create that flag in your electronic medical record that they haven't been seen in this time period? It adds so much complexity that most people would probably say it's probably not worth it. I don't want to get in trouble for seeing this person, or I don't want them to get a surprise bill. So it creates a disincentive to do virtual care, these types of policies.
So, Chad, what about outcomes of telehealth and virtual care? And obviously, urology is just but a small piece of the large pie. So maybe talk to us a little bit about outcomes, what outcomes are actually being looked at, and maybe urology, but also more broadly, maybe data that we have from medicine in general.
Yeah, so this is probably one of the hottest topics right now. In every single legislation that's passed, there's always some comment about we need a report, we need more data. Medicare program, Department of Health and Human Services need data on, and really the reason that the spending bill didn't make telehealth permanent, but instead only extended it for 2 years, is because they do want data on the impact of telehealth on access, costs, and quality. And so those are the big areas. And I think that when you look across the board, you'll see, depends on the specialty you're looking at, the condition that you're looking at. And oftentimes, even if you look at a condition like heart failure and you look at telemonitoring for heart failure, you find mixed studies. And the quote that I love is, there's a quote from Tim Cook, the technology can do great things, but it doesn't want to do great things. It doesn't want to do anything. That part takes all of us. And fundamentally in that quote, one of the reasons that you may have a heart failure study that doesn't reduce readmissions, doesn't lead to reductions in readmissions or mortality, is because it's really what you do with the technology and what you do with that data that will make an impact on care. And so I think that there are studies out there. I think there's a growing literature in this area. People have studied virtual care for the last 15 years, but until 2020 has it really become so widespread that you can actually look at what happens in clinical practice and when it's out in the wild, so to say. So those studies are coming in. Our group has done some work in urology. We've done work outside of urology, looking at how often patients are coming back within 30 days. for revisits. And, for some conditions like upper respiratory infections, we're finding that patients are coming back more frequently if they had a telehealth visit instead of an in-person visit. But then for other conditions, some urologic conditions we looked at, we're not finding the same thing. So, I think it will take some time to sort of aggregate all these and try to come up with some solid conclusion on the impacts. But, but it's an important area for sure.
Sure. So as we look forward a little bit, what are some of the new technologies? Where is this going to go in the future? And I mean, I think you highlighted a key point, which is obviously we need data on outcomes, and that's one element of it. But what are the sort of technological, I don't know, evolutions and trends that may occur that you see coming on the horizon for telehealth and virtual care?
Yeah, I think that, the COVID pandemic made made providers and patients aware of virtual care. And because of that, there has really been an explosion in digital health companies and and different ways of performing telehealth and acceptance of it. And I think the highest impact areas in the future, but beyond video visits, is asynchronous care. So being able to send a set of symptoms, or send a picture of a rash, for example, to your doctor, and your doctor replying. And all of us are getting lots of messages already, but when you accept that as a form of healthcare and you tie some reimbursement to it, that's when you're really modernizing care, because now that patient doesn't need to come in. I'm not just using up resources with no reimbursement around it, but we're basically creating a care encounter here, and completing that visit without the patient having to come in. And so I think asynchronous care is a big area, and that runs parallel with a lot of things that you see outside of healthcare. People are you don't go to the bank to deposit a check. You can do it on your phone, and do it in a way that you don't actually even need to talk to anyone. So I think there's that. The other big area is monitoring of populations. So that's called remote patient monitoring. And I haven't seen a lot of strong use cases in urology, but for other specialties or conditions like high blood pressure, diabetes, heart failure, COPD, and so forth, that's become an area that has really grown, and it's accepted by payers because it's pretty obvious that the issues that occur between visits are just as important as the issues that come up during those visits. So the idea of trying to keep patients out of healthcare facilities by monitoring them is definitely a big area. And then, of course, I don't know if you've heard of Chat GPT.
Yep.
Exactly. It's, AI is getting unleashed in the world. So, I think that AI has a huge role in healthcare, and that may be, it may not be on its own, but I think certainly augmenting some of these technologies that are coming out, like asynchronous care and remote monitoring. That's where AI can certainly play a big role. And I'm sure we'll see a explosion of that as people are becoming more accepting of it.
Well, I mean, I think your point on this concept of remote monitoring makes so much sense, because, when you look at these visits, they're occurring at a single snapshot in time. And it is simply capturing what is occurring maybe at that snapshot in time. But I think, as you alluded to, the underlying processes may be things that either don't present or present more severely or less severely. And we're just missing those events because we're just seeing it at time A, B, or C. So, I mean, intuitively, that makes a tremendous amount of sense. And really, you're right. The concept of asynchronous, I love your bank analogy, right? I mean, I never batch my checks together, or I never wait to go to the bank to make all my transactions. I mean, these are continuous and fluid throughout. And sure, maybe I do go to the bank from time to time, but not every sort of bank transaction is predicated on an in-person sort of interaction there. So I think that was a really great analogy. So let's talk about barriers, and maybe talk a little bit about maybe policy and coverage fragmentation. I'll kind of give you a few, and I'd like to hear your thoughts on it. Let's start with policy and coverage fragmentation.
Yeah, I mean, I think that's a huge barrier. And I think, for the most part, we'll see that like I mentioned earlier, that commercial insurers and the Medicaid program sort of follow suit with Medicare. But all you need is just small differences in payment or pre-authorization or steps that are needed to get the patient covered for these services that leads to just a few small differences that create a huge disincentive to even do it at all. And I think, we just had a conversation about remote monitoring, and it does make a lot of sense for our patients, but we have to reconcile that with the fact that, we have a certain amount of hours in the day, and we are already inundated with a lot of healthcare that we're providing already. So how do you take that time to monitor your patients with stones, or monitor your fluid intake of patients with stones, or other ways that you may use monitoring, like especially if it's not built into some reimbursement model that kind of compensates you for the time that you would otherwise be spent in clinics seeing patients. And so and it's fine, let's say that one payer does it, but then if most other payers don't do it, then you're not going to invest the time and resources to develop that type of a program, because it's hard to just do it for a small population of your patients. And so that's the practical reality of the truth is, in the state of Michigan, one of the largest payers in the state of commercial payers in the state of Michigan started covering video visits from home back in 2016. There was still no uptake because it was just one payer. And so that's coverage fragmentation. That's the definition of coverage fragmentation. And for that reason, no one cared that they were covering for it, because if the other payers aren't going to do it, they're not going to invest the resources to get that going.
What about disparities and sort of access to this technology? And maybe it's not exactly related, but sort of the broader concept of access to broadband, if you want to talk about that. And give us a sense of how that all plays into it.
Yeah, that's another very real barrier, very practical barrier too, is that the technology is way ahead of the real world implementation. And so just because actually I talked to a lot of vendors, and there was one vendor that was kind of touting their research, and they said that they're investing a lot in AI to make these alerts for this remote monitoring program more and more sophisticated. And I was like, well, what about the research in terms of getting patients to use it? Because you can get very sophisticated, but if a patient is not interested in using it or doesn't have the capacity to use it, then you're never even going to get past the start line. So and that's a real issue. There's numerous studies that I've looked at disparities, the digital divide, and simple things like language barriers that may inhibit the use of these types of technologies. Asynchronous care, if you can't quite understand what's being asked, then you're not going to use it. So I think that just needs to be a lens that every rollout of virtual care, you look through that lens to make sure that technology is accessible for every one of your patients. Because if you don't use that type of lens, it doesn't matter how fancy your tech is. It's just not going to be used. It's not going to be clinically useful.
And maybe one of the last things I'd ask you on is just broadly implementation, and how does this sort of factor into workflow for the average clinician, and how do you sort of juxtapose virtual care with in-person care? Just give me your thoughts on that.
Yeah, that's a great question. And again, I think you just hit on another big practical issue and practical barrier with virtual care. We are used to walking into rooms, seeing patients, completing that visit, walking into the next room and seeing the patient. In a way, we use the word patient-centered, but in a way, our healthcare system is very provider-centered. And so you have to have a change that surpass or makes, it's like you almost have to overcome something that's so simple in order to get people to use it. And it's hard to overcome that. That is as easy as it comes. You just walk into the room. And so, I think that overcoming that workflow change is difficult. I see it all the time in my role. And there has to be something in there for the provider. There has to be some major gain for patient care in order to take that. And oftentimes, the way that I view the implementation of virtual care is that it has to be high impact enough. It can't be, just doing a bunch of video visits. It has to be you're doing it in a way that's strategic, that changes your practice, that's high impact enough that it's worth it, because even a small change is very difficult to implement. I think some of the, one good example that ties into workflow changes is that let's say you have a practice that's sharing a clinic that you don't have a lot of room in that clinic to see patients. Then if one of your providers that shares that clinic is able to do virtual visits from home, the way to do it, the way to implement virtual care in that clinic wouldn't be to intersperse the video visits with in person, but actually to block them so that provider doesn't even need to come into clinic. So when you can think, and then you've had the secondary gain of freeing up clinic space to see patients, your practice may get a financial gain from that too, because you're able to see more patients that way. And so when those types of solutions come into play where you're solving a problem with virtual care, much higher likelihood of success than trying to sort of build it into a workflow that's already very easy with in-person care.
Well, Chad, that was really super. Really, kudos to you. I think you're obviously a very thoughtful person in this space. You're very eloquent. I think you sort of summarize things really well, and it was really my pleasure as a host, and our pleasure to be able to have you on this podcast with us.
Well, I really appreciate the time, and thanks for the invitation. Thanks for the conversation. It was great questions, and I'm always happy to come back, Jay.
That's super. And to our audience, thank you again for your attention. For more information, please visit auanet.org/university. And Chad, you have a great day. Thanks so much.
Thanks.